So good morning, everyone. Welcome to the Cutting Surgical Risk, Early Detection of Hidden Hyperglycemia and Anemia. This is part of the BRE and SCOAP collaboration on our BRE guidelines of surgical optimization for hyperglycemia and anemia. We will have presenters today, Patch Dellinger, Jamie Olapo, and Nick Kassebaum. So just some housekeeping reminders for everyone who's attending. Audience members are on mute. Any questions can be posted into the Q&A box or the chat box. And this meeting is being recorded. And just so you know, Vicky put also a comment in the chat box. Please check it out. If you would like CMEs, this presentation is available for CMEs. And we will send that survey out at the end of the presentation. All right. So we have some objectives for this meeting today. That you can see here to propose at least one topic for the hospital surgical quality improvement team and integrate best practices into transform surgical care in your hospital, develop an implementation plan for ongoing review of specific hospital surgical quality improvement metrics. So we have a process for claiming CME. And as I said, that survey will go out at the end of the webinar. If you have questions about CME, we will put some emails in the chat for Vicky and Emily. And this is who is accrediting our CME this morning is Providence. So you can find our full report, and I will be dropping this link to the report in the chat when our first presenter gets started this morning. So our agenda today, we will first discuss perioperative anemia, perioperative glycemia. We'll have a little brief bit on evaluation tools, and then we will have a Q&A with the speakers before we close out. Our speakers today are Dr. Nick Kassebaum, a medical director of SCOAP and SpineCope, Dr. Toby Richards, professor and founder of the and CEO of the Iron Academy, Dr. Patch Dellinger, professor Emeritus at University of Washington, Department of Surgery, and Dr. Jamie Olapo, general surgery resident at the University of Washington in the surgery department. So with that, I will turn it over to Nick to give a brief introduction. And actually, Nick, I did not pull up the video, so let me do that quickly.
Okay.
You would like to give a brief introduction here.
Thank you, Gary. Good morning, everyone. Welcome. We're happy that you're here so early on a Thursday morning to talk about anemia and sugar. The overall goal of our efforts in helping craft the BRE recommendations for preoperative optimization were to come up with a set of criteria and guidelines and a workflow that are both straightforward and evidence-based. And so some of that today is about trying to share with everyone what do we know about the impact of these conditions on patient outcomes, and what also do we know about what is possible in terms of interventions to treat and to make things better, so to speak, and how do those work, and what impact do they actually have, and over what time course. And so I personally have done a lot of descriptive epidemiology research in the past about anemia and causes of anemia and the impact of anemia on health overall, and could certainly talk for hours, if not days, about perioperative anemia. I chose instead to try to seek out one of the real leaders in this field from the clinical trials area. and was able to connect with this fellow who you're going to hear from very shortly, Professor Toby Richards. So Toby is British. So Mr. Toby Richards is a surgeon. He's a vascular surgeon, has been at Imperial College London for decades as a vascular surgeon, and in that role did a fair amount of descriptive research, some clinical research, and started recognizing more and more just the impact of anemia on his patients and chronic anemia of people coming in. And took this further and started researching, what was the impact of potentially trying to treat it. So he led at least two, if not three, of the real landmark trials in perioperative iron supplementation and giving IV iron. Trials called the Prevent trial, the ITAX trial, and something called the Iron Woman trial. And he now splits his time between London and Perth, Australia. In Western Australia, on the far southwest coast, about as far away from here as you can get in Australia. It's interesting. Is probably arguably the world leader in blood health. They have statewide initiatives, population level initiatives where people are routinely screened for anemia in primary care clinics. They were pioneers of patient blood management, or sometimes referred to as bloodless surgery, about how do we actually go about reducing the need for transfusions, and helping come up with strategies to help care for patients like those who are Jehovah's Witness, who can't accept blood products. And so it's really might seem odd for those of us who don't know it very well, but the other WA is very much a leader in this space. So Toby was going to try to join us, but it couldn't quite work out because he's actually flying. He's on a plane from Australia back to London right now. But I was able to track him down and get a recording of him talking through stuff. So,
I got that ready, Nick.
all right. And so we'll do that. And then I do ask him a couple of questions at the end. And then after that, we will save additional questions for later in the session. So please enjoy.
Great. And are you guys able to see my screen? I may have to reshare this, so give me
Yep,
just a
it
second.
looks good.
I
It
probably
looks
have
good.
to stop sharing and reshare just to make sure the sound is working. So,
Oh, okay.
sorry about that. Just 1 second. Not sure why it looks different this morning. Yeah, there we go. Okay, we will try this again. There we go. And hopefully this will work. Here we are.
Great. So I'm here today with Professor Toby Richards. Toby is going to talk to us about some of the work that he's been doing over the past decade plus of looking at the impact of anemia on perioperative outcomes. And he's going to focus especially on a couple of the trials that he's led on the impact of IV iron on outcomes and kind of share his vision for where we might be going in the future. So thanks for taking the time to be with us, Toby. He's calling in from Perth, Australia today.
Brilliant. Thanks very much, Nick. I'll just share my screen. And here we go. So my name's Toby Richards. I'm a practicing surgeon. I'm actually a vascular surgeon. And in the past, I used to do a lot of transplants. So I got very interested in the management of anemia and the avoidance of blood transfusion, because in the setting of a kidney transplant, obviously you don't want to give a second transplant, which is a blood transfusion. So how do we avoid that? And is that beneficial to people outside of the transplant setting? The trials that I've been involved in predominantly are the two big main ones called PREVENT and ITAX. PREVENT was in people undergoing major surgery, and ITAX cardiac surgery. ITAX is in press at the moment, so I'm going to talk about it, but not actually formally present it. But the information will all join up. So, where are we going?
Morning, Sir Lancelot. Morning.
In the United Kingdom, this is how surgeons are welcomed at work.
My man, you must pursue me. I suppose you got another half dozen boring cholecystectomies today. Yes, sir. After last night, I feel like one myself. How about that gastrectomy I did yesterday? Not so well, sir. Oh, pity. Great pity. Morning, sister. Morning, Sir Lancelot. Everything ready? All ready, sir. Splendid. Now, you just lie still, old fellow. I've just got to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good. Carry on. Gently, man, gently. You're not making bread. Don't forget, to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. I don't worry. This is nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find? Subcutaneous fat, sir. Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time? 10 past 10, sir.
So, the issue of bleeding has been prevalent and a problem for over 70 years since this was first presented. This is my work and my disclosures. And the issue behind bleeding is that it is a cause of anemia. Now, whether or not that's the fact that you're doing multiple blood draws or whether or not the surgeon's losing blood, the outcome is one of anemia. The commonest causality behind anemia is iron deficiency. You have 4,000 milligrams of iron in your body. Most of that is used to make the red stuff in your blood called hemoglobin. Every day, you recycle around about 50 mils of hemoglobin, which is about 25 milligrams of iron, so are almost a litre per calendar month. That iron has no natural way of being excreted from the body. The body's incredibly good at recycling. So the iron, Latin ferrum, is moved around the body by transport the iron transferrum, and is stored in the biscuit tin, the ferritin. You hold 1,000 milligrams of iron in reserve. That's enough for about 2 litres of blood or to grow a baby. Because the recycling system is so good, normal absorption from the gut is actually very poor. You need a very acidic stomach to dissociate the iron from your food, and the iron is absorbed in the duodenum at a rate of just a couple of milligrams a day. And every day you lose a couple of milligrams, mostly through loss in the skin or cells from the gut. Now, absorption has 2 pathways. The meat-based pathway is a bit like arriving at the airport and you go through the e-passport gate. It's got a dedicated channel through HCP1. But plant-based iron needs to be reduced with a strong acidic stomach, and that's where vitamin C sometimes can help, but in clinical practice is not particularly beneficial if you've got a normal stomach. And then iron is absorbed through divalent metal transporter 1 with copper and other transition metals. So if you take your iron supplements with multivitamins, these will compete for the absorption. Iron then is stored in the cell, but the control mechanism is the export of iron from the cell through ferroportin onto transferrin and interferritin. And this is all controlled by a hormone in the liver called hepcidin. So if you have high iron levels, you activate your hepcidin. That stops the transport of iron and so therefore stops the movement. And so if you have low iron levels, hepcidin goes down, you increase the ability to transport iron in and around. Now, this is relevant because in medical practice, we don't really measure iron levels. And there's a lot of debate about that, which I'll come on to later. But what we did find is in this study, almost 15 years ago, that if you're anemic, this is a risk factor and a marker of poor outcome. This was one of the first analyses of the SCOAP database. We looked at 250,000 people at 52 variables across 9 predefined domains. And what you see here is a linear relationship between anemia, i.e. low hemoglobin, and increased risk of morbidity and mortality. So to put this into perspective, 1 in 3 people undergoing major surgery have anemia. If their hemoglobin is less than 100, they are 3 times more likely to die after surgery, twice as likely to spend double the time in the hospital, and twice as likely to have complications. So the question, therefore, is if we can address this in the surgical patient, can we reduce that risk? Now, the issue in surgical patients preoperatively is that they have a disease, and a disease causes a chronic inflammation, and that directly impacts your hepcidin levels. So your hepcidin levels go up through inflammation, IL-6, whatever you want to measure. That downregulates your transferrin and it upregulates your ferritin. So you store the iron, you sequester it away, but you can't get it to the bone marrow. And if you leave that situation, it becomes an anemia, a chronic disease. Now, with oral iron, we know we won't be able to overcome that because the absorption and transport system has been blocked. But with intravenous iron, and we can give 1,000 milligrams or more of intravenous iron safely with the same side effect profile of IV contrast or any antibiotic in 15 minutes, we know from the existing randomized controlled trials that intravenous iron is superior to oral iron to increase hemoglobin levels in a faster and more effective manner. So the interesting thing is, because you're doing 1,000 milligrams of iron, and I'm aware in America that many people do multiple doses of 200, but you know, when you take your car to the petrol station, do you fill it up 5 times or do you just fill it up once? Common sense dictates you fill up the tank in one go. The beauty about that is the more anemic you are, the faster the response because you've filled up the tank, i.e. you've provided all the building blocks. So, and when you look at the existing trials in surgery, that definition of iron deficiency is spurious at best. Many of the randomized controlled trials just looked at anemia, and if they did look at iron deficiency, it was a mixture of functional iron deficiency, i.e. a ferritin less than 100 or TSATs less than 20%, and very few, only a quarter, were absolute iron deficiency, which is a ferritin less than 30. So the argument was, if you're anemic prior to major surgery, the assumption is the main causality is iron deficiency. And what we know from the clinical trial data is that intravenous iron is just as effective across all the causalities of iron deficiency in that setting. So if you're anemic and we give you intravenous iron, do you feel better? Do you get better? And do you have less complications? And that was the hypothesis behind the PREVENT trial. In this trial, we randomized 487 patients in a double-blind manner, so the patient had no idea, the assessing personnel had no idea what they got, and we followed up 97% on the intention to treat analysis, and per protocol, about 80% exclusions there. What we showed was intravenous iron compared to placebo, i.e. standard of care, did result in an increase in your hemoglobin at all time points. But interestingly, the greatest increase was actually after people had surgery and they got home. I'll come back to that. But surprisingly, the results of this trial were no superiority of intravenous iron over placebo. The transfusion rate, which was the primary endpoint, was exactly the same in both arms of the trial. When you look at the subgroup analyses based on age or sex, baseline variables, or the type of surgery, again, no differences were seen. Interestingly, a second trial has come out called the FIT study, where they took people undergoing colorectal surgery and they randomized them to intravenous iron versus oral iron, again, about 2 to 3 weeks prior to surgery. They showed similar results. The two graphs below show the increase in hemoglobin, which was a little bit prior to surgery, but maximal about a month after surgery. And again, this trial showed no benefit of the in-hospital transfusion rates or complication rates in hospital. But interestingly, when you look at this in more detail in a subgroup analysis, we had all the baseline variables as markers for iron deficiency. And in those people who had absolute iron deficiency of ferritin less than 30, which is about a third of those who are anemic, so about 1 in 10 people presenting for surgery. If you give them intravenous iron compared to placebo, you get about an 11 grams per liter rise in their hemoglobin prior to major surgery. And personally, I would argue that that is a clinically significant difference. And post-operatively, again, you see a higher rise in the way the hemoglobin recovers. In those with functional iron deficiency, this is the working assumption that inflammation is leading to iron sequestration. After surgery, and this is big surgery these people had, the most common operation was a Whipple's pancreatoduodenectomy, followed by a gastrectomy or a total colectomy, all big open surgery. The hemoglobin recovery after surgery was significant. So to me, this makes me think that the blood loss trigger for erythrogenesis is overpowering the inflammatory stimulus of iron sequestration. And that's my thought from the outcome of these trials. But the beauty about doing randomized controlled trials is you can add the data together. So in PREVENT and FIT and a couple of other trials that were a bit smaller in colorectal surgery, we added all the data together from these trials, and we showed that intravenous iron compared to standard of care significantly reduced transfusion rates in those undergoing lower bowel surgery, so colorectal surgery. And this goes with the working hypothesis that the causality is blood loss. Then providing intravenous iron in a big dose enables the body to regenerate the blood. But if the causality is inflammation secondary to cachexia, for instance, in pancreatic cancer, and whatever that inflammatory status is, then the use of intravenous iron may not be as effective. Now, what's the relevance of all this, and how do we take this forward? I, to date, have only been talking about anemia and the outcome of transfusion. But iron is vitally important for many other functions. If you think about it, hemoglobin just delivers oxygen to the tissues. So to deliver more oxygen, you could just breathe a bit more, really, to be honest. But inside the tissues, oxygen plus food undergoes aerobic metabolism in the mitochondria to convert to ATP and energy for the cells. Those enzymes, those cytochromes, all have iron as the key component. So does iron deficiency have an impact on muscle function and fitness? So to assess this, we undertook a series of studies here in mice where we made mice iron deficient and we compared them to iron replete mice and exercised them, and in a minute in exercising females. What we showed is if you make mice iron deficient, the exercise capacity significantly reduces and it halves. If you then give the mouse an iron infusion, you significantly increase the ferritin level within 48 hours. And within 48 hours, the exercise capacity returns to the same as the control group. So why is this? Well, this is one of our PhD students, Dr. Kassebaum, who did oxidative phosphorylation analysis, so looking at the generation of ATP. And what you can see is in the soleus muscle, which is predominantly aerobic compared to the quadriceps, the impact of iron deficiency reduces ATP generation by about threefold. And if you give someone intravenous iron, a mouse intravenous iron, within 48 hours, that capacity is returned to normal. So I put to you that the impact of iron deficiency has a direct impact on muscle function. And I'll come back to this in a second. When you look at exercising women, this is a rather complicated slide, but essentially it's called the Iron Woman Study. We randomized exercising women through a community screening program with iron deficiency. And we showed that if you treat the iron deficiency, you improve exercise capacity, exercise economy, and if you correct hemoglobin, you increase VO2 max as well. Why is this all relevant? In the PREVENT trial and the FIT trial, I mentioned that the biggest benefit in hemoglobin recovery was actually at about 1 to 2 months after surgery, after discharge from hospital. The causality of the anemia at that time point is likely to have been the surge and loss of blood and multiple blood testing, i.e. blood loss. In those people that received intravenous iron, the rate of unplanned readmissions for complications to hospital was halved in the intravenous iron group compared to the placebo. Same results were shown in the FIT study. These were reported in the primary manuscript, but were missed entirely. And it's really relevant because in the ITAX trial, we've randomized 1,000 people prior to major cardiac surgery. And the endpoint is days alive and out of hospital at 90 days. So a combination of time in hospital at the original operation and time in hospital for complications. And that's very relevant because in PREVENT, we reduced length of stay in hospital for complications from 785 days to 556. And that is markedly significant. When you look at it, okay, there's no statistics here. This is just Mark 1 eyeball assessments. The big impact was in infection, whether or not it was general or in wounds. I put that there as a trend. There are no statistics associated with these slides. It's just raw data. So my question is, have we learned in the last decade that the problem is actually anemia after surgery rather than before surgery? So to address that, we did an international study where we audited people's hemoglobin and follow-up after major surgery. We collected data on all the usual things, but importantly, clinical frailty score. And what we showed is that if you have anemia on discharge, particularly a hemoglobin less than 100, which affects 1/3 of people after major surgery, this increases their 30-day readmission, and it significantly increases their clinical frailty score. So if you start tying this together, muscle function, oxidative phosphorylation, the use of iron, then you actually see in meta-analyses that the use of intravenous iron after surgery is just as effective to correct hemoglobin as intravenous iron prior to surgery. It's also an awful lot easier because the patient's sitting on the ward with a line in, having nursing obs. And so if you put this all together, the use of, what do we know? The use of intravenous iron prior to major abdominal surgery doesn't necessarily impact the perioperative care of patients, but it has a huge impact in terms of hemoglobin recovery after surgery. In 2 large clinical trials, this has been associated with a reduction in readmissions. In the ITAX trial that randomized 1,000 patients with a primary endpoint of days alive and at home at 90 days, if you include that time of readmission, there is a statistically significant reduction in days alive and at home with those who got the placebo. So intravenous iron improved days alive and at home in that regard, and it ties together all the knowledge that we've gained over the last 15 years. So the summary is, who should get intravenous iron prior to surgery? Blanket therapy to all, no. Colorectal cancer patients, either causality is blood loss, very sensible. And if someone has a ferritin less than 30, absolutely. But all people in hospital with a ferritin less than 30 should have intravenous iron. Oral iron doesn't work in a hospitalized patient. 5 randomized controlled trials to show no benefit. What is iron deficiency in surgery? All I can say after 15 years of studying this is that inflammation is cleverer than I am, and I don't truly know the answer to that. What I do know is that it looks like about 4 weeks after surgery, the blood loss trigger is greater than the inflammatory sequestration. Should we give iron to everybody after major surgery? Well, I just need someone to give me the funding and we can launch that randomized controlled trial. Thank you very much.
This is wonderful, Dr. Richards. Thank you so much for sharing your experience and insights with the group. Just a couple of quick follow-up questions as we start thinking about how we would operationalize anemia optimization, and especially like who and how to treat absolute iron deficiency in the surgical population. So you mentioned everyone who has absolute iron deficiency and in colorectal surgery. And though there's not a trial, what would be, if the mechanism is blood loss, what would be your opinion about operations like trauma and also like major complex spinal surgery or vascular surgery, your own clinical specialty? Would those likely also have a similar mechanism?
So funny you should mention vascular surgery. We are just about to launch a trial in vascular surgery looking at the use of intravenous iron and how it might improve walking distance, frailty, and recovery after surgery. Where I am today, my personal opinion, is that in people prior to major surgery, they should have their folate, ferritin, and B12 checked. As with any deficiency, such as hypertension or diabetes, that should be optimized prior to surgery. If someone is profoundly iron deficient with a ferritin less than 30, I would probably delay their surgery a week or so, unless it's pressingly urgent. And so that's where I am today. So if you're setting up a program, I would start with GI surgery. I would, at endoscopy and colonoscopy, where you've got the patient on the table and you're making the diagnosis, draw the bloods and treat there if you know. It's the perfect opportunity.
Nice.
In hospital, my suggestion and my own clinical practice is, if I operate on someone and their hemoglobin is less than 100, and when they come off the table, they've had major surgery, so you've got blood gas, hemoglobin comes back 95, I give them a bag of intravenous iron in recovery. And my personal opinion, where's the greatest gain for this? Women having a cesarean section. 2/3 of all women in pregnancy will experience iron deficiency and 1/3 will be anemic. I think there is a huge a lack of evidence here, but what we know is from your work, Nick, is that women of reproductive age are disproportionately impacted by anemia. The commonest cause is blood loss. That's either hemorrhage from heavy periods or it's childbirth. These are otherwise fit and healthy individuals. The use of oral iron in this setting is, well, poor. Most women spend 2 to 3 years on oral iron. Most women suffer for around about 8 to 10 years with iron deficiency. No self-respecting man would put up with heavy periods and anemia for 10 years, would be down the pub talking about it. So why do we discriminate against women in this regard? And if I had a magic wand, any woman having a cesarean section with a hemoglobin less than 100, after that, I would give them a bag of intravenous iron in recovery. We know that it will help recover their hemoglobin and their iron deficiency. And from your forthcoming work, I think there's a huge benefit to both physical and mental health for this rather what can be a fragile population.
Wonderful, amazing. Well, I think that's all the time we have. Hopefully, we can get you to be here in person at some point. Would love for you to be able to meet the group and continue to spread the great work you're doing. Thanks so much.
Brilliant.
And I'm going to move our. There we go.
All right. So I hope that was an insightful and helpful presentation as much for you as it was for me. I think I'll let Professor Richards speak for himself there. The summary takeaway of this and how it relates to the recommendations that we published at the very high level, 3 steps. So for all patients coming for surgery where blood loss is even possible, screen for anemia, check their hemoglobin levels. And if their hemoglobin is less than 13, in the British system, they use grams per liter rather than grams per deciliter. So you're saying 100 or 110. So less than 13, perform iron studies. And if their iron is low, which is most universally captured by a transferrin saturation under 20%, give them IV iron and make sure you give enough to actually fix the deficit. While you may not necessarily have an impact on what happens day of surgery for some patients, for some you certainly will, you're likely to have a very big impact after the surgery, post-operatively, and post-discharge. So I'll stop there, and we'll happy to take questions later in the session. Thank you.
Great. Thanks, Nick. So I would like to invite Patch and Jamie to come forward. And if you guys can just tell me when you'd like the slides forwarded, that would be wonderful.
Okay, well, good morning. This is Patch. And we're going to talk about perioperative hyperglycemia and why it's actually more dangerous for non-diabetics than for diabetic patients. Next slide. So I became interested in this back around 2000 when I was asked to review this paper in Infection Control Hospital Epidemiology. They looked at glucose control in the perioperative period for patients having cardiac surgery. And you can see that with increasing glucose levels, there was increasing infection rate. Next slide. What really got my attention in this and caused me to write a commentary published in the same issue was that there was risk for both diabetics and non-diabetics, and it was related to hyperglycemia in the OR in the immediate post-op period, and it occurred both in patients with diabetes and patients without diabetes. and hemoglobin A1C, which a lot of people focus on for diabetics, did not influence risk. Next slide. And what we saw was that of all the patients with hyperglycemia, almost half of them were not diabetic. Now, of course, for an individual patient, a diabetic is more likely to experience hyperglycemia than a non-diabetic, but there are more non-diabetics, and half of the hyperglycemic episodes were in non-diabetics. Next slide. This caused us to start looking around at other aspects, and initially the concept of the risk of hyperglycemia was at first focused on cardiac, but it actually influences every kind of operation. Here's a study looking at vascular surgery, and again, we see increased postoperative infection with increased glucose levels. Next slide. Here's one with mastectomy, and you can see that any patient having a mastectomy with a glucose level over 150 had almost 3 times the infection risk as patients with less hyperglycemia. Next slide. Here's one for general surgery. Same conclusion. Increasing glucose, increasing infections. Next slide. So the takeaway, hyperglycemia is a problem. It increases the risk of complications across all surgical specialties. Next slide. We got interested in this, and when I first saw that paper, I discussed it with our general surgery division at the university. And one of my faculty said, well, look, if this is an issue, why don't we start looking at it in our patients? And so we began figuring out ways to control perioperative glucose levels in general surgery at the U. And we also involved the Surgical Care Outcomes Assessment Program, or SCOAP, which looks at a large number of hospitals across the state of Washington. And we got data on over 11,000 patients having colectomy or bariatric operations. And you can see, again, that while hyperglycemia was more occurred at greater levels in diabetic patients, as you would expect, nevertheless, 30% of all SCOAP patients in the state of Washington who were hyperglycemic were not diabetic, really emphasizing the importance of focusing on all patients having operations, not just diabetic patients. Next slide. And this is from the same paper, just looking again at the increased risk just in non-diabetic patients for any glucose in the perioperative period above 180. And you can see that there was a huge increase in infection rates. Next slide. And one of the other things that Kwan's paper showed was that for patients who had hyperglycemia, patients who were treated with insulin had less increased infection risk. We're looking at the odds ratio here. On the left, patients who did not get insulin for hyperglycemia. On the right, if patients did receive insulin for hyperglycemia, their odds ratio was improved. Next slide. Next slide. The other thing we found in another paper looking at SCOAP data was who gets insulin. So for what we see, the height of the bars here indicates how many patients got insulin. And on the lower level, you see the blood glucose measured. And you can see for every increased level of glucose, diabetics were more likely to get insulin. Non-diabetics were less likely to get insulin, even though they have an increased risk of infection with the high blood sugar. Next slide. This is another study done on hyperglycemia for colorectal operations, and they followed over 5,000 patients. And again, they found 43% of hyperglycemic episodes were in non-diabetics. Next slide. And once again, you can see an increase in superficial SSIs, in sepsis, and in mortality. And once again, significant in non-diabetic patients. Next slide. So when it occurs, hyperglycemia is worse for non-diabetic patients than for diabetic patients. Maybe because diabetic patients' bodies are somehow adjusted to the chronic hyperglycemia. Next slide. So in this paper, the other thing that they looked at, again, at over 55,000 patients in the VA system with careful postoperative monitoring, all the usual risk factors were significant, but the hemoglobin A1C was not significant, and people overemphasize A1C. A1C tells you if a diabetic patient has chronic hyperglycemia, but in terms of surgical risk, it's hyperglycemia at the time and immediately following the operation that is significant. So in this group of 55,000 patients, patients with hyperglycemia had significantly increased infection risk, but when you did a multivariate analysis, hemoglobin A1C had no influence at all. Next slide. This is just another study just to show, again, looking at diabetic patients, there was an odds ratio of a 20% increase in mean glucose causing a 27% risk of complications. But when you did a multivariate analysis, hemoglobin A was not significant, but the mean glucose in the perioperative period was very significant. Next slide. And another study, this is an interesting study. What they did, Jones looked at patients who had an elevated hemoglobin A1C before the operation. And what they found was that patients in this study, where they worked hard to control perioperative glucose levels, patients with elevated A1C actually had a significantly lower complication rate than patients with normal A1Cs. Next slide. And what happened is this slide shows how frequently glucose levels were checked and insulin was given for high levels. And what it shows is that patients with higher A1C were followed more closely with more measurements and more treatment. So even if your patient coming in for an operation has a high A1C, if you aggressively measure perioperative glucose and control it, you reduce the risk. Next slide. So an elevated A1C might tell you that it's going to be more difficult to control perioperative glucose, but if you do control it, you will reduce the patient's risk for serious complications. Next slide. And this is just one more study showing the risk for non-diabetics. This is at the Cleveland Clinic, significant number of patients. And again, there was an increase in mortality, in sepsis, in surgical site infections, and in reoperations, increasing with increasing perioperative glucose levels, all in non-diabetics. Next slide. And looking here at SCOAP data again, what we see is that there's an increased risk. We have patients with diabetes on the left, patients without diabetes on the right. And for every type of complication you see for this similar level of hyperglycemia, non-diabetic patients had higher rates of complications than diabetic patients. Next slide. And we looked just within the past couple of years at blood glucose levels in patients having general, vascular, or OBGYN operations at the University of Washington Medical Center. We looked at 5,800 patients, 16% diabetic, 83% non-diabetic. And once again, what we see here is that having a higher blood glucose level was more common in diabetics than non-diabetics. Next slide. But looking at the complication rate for each elevated glucose level, we see diabetics in green and non-diabetics in white. And for every level of elevated glucose, non-diabetics had higher complication rates. Next slide. Okay, I'm turning this over to Jamie now.
Awesome. Thank you, Dr. Dellinger, for setting that up. Carrie, I'm going to have some animations here, so if you could just click next. Awesome. Thank you. So, and you can click next again here, Carrie. What I think that, Dr. Dellinger presented an overwhelming amount of evidence for is that this is definitely a problem. Elevated blood sugar is a problem in diabetic patients and non-diabetic patients alike, but we see this paradigm where non-diabetic patients are less likely to receive more frequent point-of-care glucose checks, and then therefore less likely to receive insulin treatment for the same levels of hyperglycemia. So we have this gap in what's happening. And then if you could click next again here, Carrie. So that leads us to think about what we need to do to standardize perioperative glycemic control in our non-diabetic patients. And I want to introduce the idea of prophylactic insulin and prophylactic management of blood sugar rather than treatment of it. Click next again. All right, one more time. Awesome. So I think, anyone on this call recognizes that perioperative blood glucose control is something that we are very familiar with as surgeons and any team that's taking care of patients in the OR. We all can acknowledge that surgical stress can cause hyperglycemia. Next, click, Carrie. And that this is something that we are already bringing awareness to with a number of ERAS protocols that are actually specifically targeted at avoiding hypoglycemia with carbohydrate-rich drinks for up to 2 hours pre-op. And then both Virginia Mason and UW actually have established nursing guidelines to help achieve blood glucose goals and other hospitals alike, but these are just a couple examples. But my goal here is to make a case for more standardized perioperative guidelines for all patients, including non-diabetic patients as well. Click next. So SAMBA, or the Society for Ambulatory Anesthesia, routinely publishes guidelines for blood sugar management perioperatively. And they specifically state that a pre and post point of care check is standard for surgeries that are over 2 hours in length. But then the guidelines get a little bit more vague and they state that more frequent monitoring can be recommended. And in non-diabetic patients, actually, these guidelines state that only significant periprocedural hyperglycemia of over 250 can be treated with insulin. And Dr. Dellinger previously showed you that the risk of increased surgical complications starts far below this threshold that's in these guidelines here. So therefore, the need for standardization of practice to prevent hyperglycemia in the OR, it needs to become really as standard as pre-op antibiotics that we're familiar with. So if we specifically talk about UW, for example, patients receive one point of care check in the pre-op area. And it's not unless they're on an insulin infusion that they would receive Q 1 hour checks intraoperatively during the case. There was a study that was done at Vanderbilt, and they implemented a clinical decision support tool, which prompted more frequent checks of blood sugar in the electronic medical record, and found that this significantly reduced the rates of hyperglycemia due to earlier detection in treatment in all patients. Click next, Gary. But also, I do want to acknowledge that it goes without saying that frequent point of care checks takes more time on the providers that are taking care of these patients. And an average point of care check is about 3 to 5 minutes to perform. And so we can also talk about the rising use of continuous glucose monitors in the outpatient setting as an opportunity to implement this technology in the OR. So continuous glucose monitors work through a tiny sensor that's inserted under the skin, and they measure glucose levels in the interstitial fluid, actually. And then there's an algorithm that estimates the blood glucose level from that. There was a recent systematic review here, and this looked at the safety outcomes. If you could go back really quickly. Okay. So, looked at safety outcomes of over 1,000 patients who were using CGMs in the perioperative setting and wore the device in the OR. And out of these 1,000 patients, there was only 6 device-related adverse events. So really, this is pretty robust to demonstrate that this technology is safe to use in the operating room. Next slide. And mechanistically, this can be twofold. So treatment insulin, of course, is correcting blood sugar to get back into range, but the idea of prophylactic insulin has long been used in the world of cardiac surgery. So for many years, there's been over 30 randomized clinical trials in which cardiac surgery has administered insulin in the form of a glucose, insulin, and potassium solution. And this has reduced the incidence of major cardiac events compared to control or patients who weren't receiving this intervention. Click next. And so that might be because not only are we receiving improved glycemic control, but there's also anti-inflammatory properties of insulin, which was demonstrated over and over again in these cardiac studies by reduced CRP and other circulating inflammatory markers. But I want to highlight a gap here that the use of this solution, GIK, has never been evaluated in preventing adverse outcomes in stress hyperglycemia in abdominal and pelvic surgery. Click next. So here I want to introduce lastly the idea of a pilot trial that was run and organized this last year at the University of Washington. And this is called the Patches trial. I'll give you guys one guess where this name was inspired to based on the other speakers here at this webinar, but this trial was looking at prevention and treatment of hyperglycemia in patients who were undergoing abdominal and pelvic surgery. Click next. Our population actually specifically was looking at non-diabetic patients who were undergoing either a variety of general surgery cases. This included minimally invasive, open cases, surgical oncology, gynecology cases, urologic cases, a large variety, and patients who did not have a documented history of diabetes. Their surgery length was planned to be longer than 3.5 hours, and they were planned to have an inpatient admission. Click next. So our intervention was utilizing a glucose, insulin, and potassium infusion, and this was weight-based. This was a double-blinded study, and patients were randomized to either our intervention or a saline placebo. The intervention was started in the pre-op area, and then this was continued through the entire duration of the case, and it was discontinued in the PACU when they were coming to recover. You could click next. And our primary outcome was really, one, was this a safe intervention? But then also looking at the rates of hyperglycemia between our treatment groups, the need to administer additional therapeutic insulin, and then also looking at NSQIP-defined perioperative adverse events. Click next. So I really want to highlight in our pilot trial, we had 100 patients who we enrolled, a little over 100 patients, and blood sugar was monitored hourly during the case. So we have pre-op measurements, hourly time points during surgery, and then also post-operatively as well. And so we saw there was a significantly increased time spent in a euglycemic range, which we defined as a blood sugar less than 125, in our patients who were receiving our intervention. Click next. And then Also, that there was a significant increase actually in patients who were experiencing hyperglycemia, the patients who were not receiving our intervention. And again, remember, these are all non-diabetic patients. Click next. And then one more time, Gary. Yeah, excellent. So that there was a reduced need for additional insulin to be given to respond to hyperglycemia in our group that was receiving our intervention. So altogether, prophylactic insulin in this patient population promoted time and range and also required less treatment insulin. So this was all supporting our idea that prophylactic treatment with insulin can also be effective here. Click next. And then one more time if you could click next. And so then why does this matter here? Back to the point that Dr. Dellinger had set up with all these previous studies, this translated to a reduction in adverse events in this group as well. So we can see that we have an odds ratio here. Patients were less likely to experience an adverse event in the 30-day postoperative period who were receiving our treatment versus placebo alone. Click next. So excellent. So I'm really excited to have shared some of those preliminary findings with you. This is a study that's going on right now to be developed to a full-scale trial, and hopefully we'll be able to be continuing that within the next year. But if I were to summarize everything that Dr. Dellinger and I spoke about today, I just want to emphasize that hyperglycemia in all patients, diabetic and non-diabetic patients alike, increases the risk of morbidity and mortality in patients, and that this really disproportionately affects non-diabetic patients, and I want to bring that to our awareness as part of our algorithm that we're thinking in our mind and how we're optimizing these patients for surgery. And that treatment with prophylactic insulin may actually be better than responding and correcting hyperglycemia. And that is all I have. Great, thank you.
Great, thank you very much. We are going to have one more little section here. So these reports that the BRIE did were created specifically in collaboration with SCOAP, and we've thought a lot about how organizations can kind of evaluate their own implementation of the guidelines from the BRIE collaborative. So we really want to think about, we thought about how we could measure for quality improvement, and also align across different organizations so that they're all measuring the same thing. We at the BRIE are providing some resources for evaluation for small organizations in particular, because the UW and others are, obviously very much larger institutions, and not every hospital has the same thing. And we have some non-financial incentives for sharing your evaluation with us, which I will talk about in just a second. So as part of the work of developing these guidelines for surgery optimization, we created an evaluation framework. This is a living document, and we're going to be continuing to develop this evaluation framework as we go along. We'll be holding a working session at the SCOAP conference this year to further kind of flesh out the measurements in this framework. You can reach the current version here with this QR code. But it has some recommendations for sort of measuring programs as a whole, including your patient experience, and including some ethical standards in terms of like your quality improvement program, making sure that you are doing things equitably, all sorts of different recommendations in this document. And this group also created this theory of change of how implementing surgery optimization will change, impact the population of Washington state. So we have some impact measures that this group developed. It's really the kind of the process measures and some of the measures for anemia in terms of like the epidemiology of this work that we will be still kind of fleshing out in the SCOAP conference. If you are interested, and Patch and Jamie, you guys may be interested in this, The BRE Collaborative has created these scorecards. So these are specifically for health delivery systems, surgical teams, preoperative clinicians, and the health system as a whole. We also have ones for health plans and purchasers, but they're not really relevant here. In order to kind of help encourage organizations to report their data on how they are changing their clinical practices, we have developed these scorecards, and organizations can turn them in and receive awards from the BRE Collaborative and the Foundation for Healthcare Quality. So we have 3 levels of awards. We have the Pathfinder Award for organizations that are just starting on their implementation, really demonstrating that they are just thinking about or are at this beginning stages of implementing the changes that this report recommends. We have the Trailblazer Award for organizations that are more like Jamie's and Patch, where you guys are kind of well on the way to doing this and being leaders in this area. And then we have the Mountain Climber Award. So if you've won a Trailblazer Award, we have the Mountain Climber Award annually, and it really focuses on equity. So making sure that all people in Washington State are receiving the same sorts of clinical care and how you implemented that in your organization. So if there's anybody who's interested in this, I would be happy to discuss it further. I'll be dropping some links for my email in the chat as well. So I would like to move now to our Q&A portion. And Nick, let me see if I can escape from this and stop sharing my screen. All right. So Nick, if you would like to unmute, and I would like to open this up for Q&A. You can either put questions in the chat box, or let me find our Q&A box. There it is. Or in the question and answer box, if you have questions for either Nick, Jamie, or Patch. And if you are, I think I could see hands raised. We only have 11 attendees, and I can also just unmute folks. That would be better. Oh, I see one hand raised. Janice. I think you can unmute.
I'm Janice Tufty, and I'm a patient partner who did work on this or, participated. I found it very interesting, and why I became involved is because I had a personal experience after a hip surgery where I became very ill afterwards, and trying to figure out why I was just failing, right? I wasn't doing well. It was a day surgery. And a day later, I couldn't eat. I just felt horrible. And they admitted me into whatever, kind of like a rehab at Kaiser I was there for 4 days. But I realized later what went wrong. And I really feel my doctor thought it was pain, but I don't think that was it because I was able to walk immediately afterwards. But I saw my glucose, numbers looking afterwards, and I realized, wow, because I am non-diabetic, I could not believe how high they went. They didn't go to 250, but they went, like 190 or something. And I really feel that that was what I would consider failure to thrive. And I don't know, you know, I didn't know anything about like the glucose and the inflammation markers before. I have had anemia issues before, but that never that it impact since I'm not having my period anymore, that's gone and done with. But I'm just curious how we might get this information out to patients as a possible complication afterwards, because I think a lot of patients that aren't diabetic aren't aware that this could happen. And what you showed today, Dr. Dellinger, is really impressive of how the readmissions happen and very serious complications in infant infection. I did not have infection, but I just flat out had failure to thrive and actually fainted at one point, right? Everything just crashed, like third or fourth day in the rehab. So, and then I came right back, right? So I don't know. Anyway, I just think it's important that we get this information and that it could be included both situations for patients. Thank you.
Yes, sorry to hear about your post-operative experience, but when you say that, patients are not aware of the importance of glucose in the perioperative period, a lot of surgeons and physicians are also not aware of this. And I think it's important for us to get the word out, and that measuring and controlling this can make a big difference.
Yeah, and that for people like myself that aren't diabetic, just to be aware this could happen. You're right. I will talk to my surgeon about it. I mean, I mentioned to him, I said, I noticed my glucose was really high when I saw him at 6 weeks. He goes, well, that's kind of common, but I think it really attributed to how ill I felt, right? And so, anyway, appreciate both of your comments. Hope other people have questions.
Thanks, Janice. Yeah, please feel free to raise your hand if you have questions or drop information in the chat. You can put a question in the chat as well.
Yeah, I see a question here in the chat, Carrie, which I'm happy to talk about. Yeah. So it is interesting how insulin was used. The question, I can just read it for everyone, was uh, this is from Eduardo, and he asked, he was intrigued by the evidence presented for the use of prophylactic insulin in perioperative complications in cardiac surgery, and just looking for a brief summarization of the evidence in different types of surgery. Well, that's exactly the that's exactly the evidence gap. The use of prophylactic insulin in cardiac surgery was actually originally used to prevent inflammation, less focused on optimizing blood glucose, but knowing that insulin has anti-inflammatory effects, specifically through actually the nitric oxide pathway. And so that is how it was originally looked at for improving complications in cardiac surgery patients with improved myocardial function and reduced circulating inflammation like CRP. So this actually hasn't been used prophylactically in other types of surgeries. And so that's why we're piloting this work, looking at it in general surgery and really taking what they have used to pilot that and have demonstrated as safe in the cardiac surgery patient to try to duplicate and see what those effects are in more of a general surgery population. But it's a great question. Why isn't this done in other surgery types? That's exactly what we're trying to do.
Thank you. If there are more questions, feel free to raise your hand and I can take you off mute, or you can drop in the Q&A. I see. You find who has their hand raised here. There we go, Rob. Go ahead, Rob.
Can you hear me?
Yes.
Okay, so I'm a general surgeon at Peace Health. We're not a SCOAP member, but we certainly are interested in every aspect of what you all talked about today. And so I'm interested in the grading portion, or not the grading portion, but I guess I'm looking at it as a grading portion because I know that the focus of our hospital right now is completely on financial solvency. And so when that happens, these quality initiatives, as long as they aren't, standard of, well, how should I say it, acceptable standard of care, people don't pay attention to them. And so when we fill out this, my interest is in that, in the survey, I forget what you call the tool that you're going to be using for figuring out these awards. I'm more interested in what the benchmark is of that score that you're going to calculate and where people fall on it. So is that also going to be available? It's where a hospital would compare to the others. Um, can we get that from this? Is that possible?
Yeah, that's a great question, Robin. Actually, that is the intent of these scorecards. I think that SCOAP offers a unique opportunity. If many hospitals are filling these out, taking the time to fill these out, then we at the foundation would be able to convene a group like that to compare and discuss where you are at the moment. That is something that we have been thinking about towards the end of this year. The real barrier there is just getting people to participate. But yes, they are. The way the score is calculated, it is a self-report. Those scorecards are available online right now, and you can look at them and see, kind of what the questions are. And it is, you can look at the different types of audiences as well. So there may be one audience that is more, engaged than another. Maybe clinicians are more engaged than administrators, but that would be what we would be interested in learning is where to start, what group to start with. And we are happy to facilitate anything that can help move this into a more common practice. Does that answer your question?
Sure does. Thank you so much.
Great. And I have a question in the Q&A from an anonymous attendee, so probably somebody on the phone. What are your top 1 to 2 takeaways from the report? Where should health systems start to make changes? And Nick, you led this group. Do you want to answer that, or?
I wouldn't say that I led it, but Dr. Olden really was our leader. Certainly participated a lot. So my top 2 takeaways, number 1 is that routine screening is both possible and should be mandatory. And we've given 2 examples of anemia and hyperglycemia. And then number 2 is there's a lot that have been published about both of these topics, if we want to call them topics, of hyperglycemic control and anemia management. But if you boil it down, it's actually really simple. Is keep track of where people are, keep track of where they're going, and be on top of treating it. And that applies to anemia in terms of, and that certainly, as we've seen from Jamie and Patch, even more so applies to glycemic control. And just the magical thinking of, oh, it's a small thing, it's probably going to be fine. Like that's the trap that ends up hurting people.
Thanks, Nick. Carl, I unmuted you. If you would like to add anything, you're welcome to.
Well, I agree. And again, the whole premise of the work group was also to see where could we in primary care who generate many of the referrals to surgery, where could we be more consistent about screening and identifying individuals who are anemic and working up anemia and treating it before patients get to the point of scheduling surgery. At the same time, obviously, the better we control diabetes, the better. But identifying those folks who are at risk for hyperglycemia and looking at modifying risk factors and also communicating with the surgical team that we are concerned about what will happen with them so that patient who is non-diabetic who shows up who is hyperglycemic gets more attention in surgery. And a big part of that is the communication, which frequently doesn't happen. Not everybody has a primary care physician. Not everybody has a primary care physician who's actually part of the surgical referral process, and us doing a better job of prepping patients for our surgical colleagues to operate on safely is a big part of this and a wonderful part of the collaboration.
Thanks, Carl. And I think that does go back to Rob's question too about these scorecards. So they are available also for primary care and for kind of the administrative level of the coordination of primary care and surgical care. So I think there's a real value in organizations submitting those scorecards so that we can convene and figure out how to make this a more seamless practice as a regular course of care. All right. I think we have time for one more question, if anybody has any. I'm just going to check the chat box here. Okay. I'm not seeing any, so I'm just going to share my screen one more time. And here we go. So, how to claim CME. I have dropped some links in the chat. If you would like to claim your CME, you can follow those links. There's an evaluation surgery there's an evaluation survey. And then at the end of that survey, you will find a link to the CMEs. So it's a second survey specifically to claim CMEs there. And if you have any questions, my email is in the chat. I will also drop Emily's in the chat. My apologies. So we have these upcoming events also that I just want to make you aware of. We will have another surgical patient optimization presentation. We will have a surgery and spine COAP annual meeting. We will be discussing the evaluation framework a little bit more, but also lots of information about these two topics of hyperglycemia and anemia at our annual conference. Other events, we have some spotlight reports that are available currently online for our other BRIE-reports, and some Catalyst of Change webinars through the BRIE, and also we are doing a little bit of work around vaccine hesitancy and keeping up with different guidelines. So we would invite you all to join those events, and we hope to see everyone at our annual meeting. Thank you all for your presentations, and I hope that everyone has a great start to their day. Take care.
Thank you, Carrie. That was great. Thank you very much.